Okay, people, we're going to try this for a third and final time. I'm at home. Lighting is different here. I look a little jaundiced. I'm just saying. Just ignore this. There are no PowerPoints for this review. So we're just going to breeze through this. I have got pulled up the PowerPoint here that Wendy narrated for you. So I'm going to go a little bit quickly through this and not spend much time giving you my viewpoint. How I teach. No, we're not going to do that. I'm just going to tell you what the slide number is so that maybe you can go to that slide where you took notes and refresh your mind a little bit. If you get stuck, because remember, you've already studied for the exam, and now I'm just going to reiterate, make sure that you have most of the information for the exam. I don't have a copy of the exam at home, so I have no idea if I'm covering everything. So we're just going to go from here. Okay, and I don't have access to my notes that I had earlier, so we're just going to roll with it, okay? Okay, so first of all, we go over to the A and P. This was the second PowerPoint that you viewed that Wendy narrated. It is A and P and neurodegenerative diseases. And so I want to quickly go over that. I think there's only one question on A and P from the PowerPoint that's on this exam, and it was basically about the brainstem. So you may want to go back and review that about the brainstem. But the first thing that we want to review is signs and symptoms of multiple sclerosis. This is on slide number 4. So you want to look at the motor symptoms, the sensory symptoms, and other symptoms. Now, one thing that I wanted you to really look at, that if you look at most of the signs and symptoms that a person with multiple sclerosis may exhibit, then most of them are due to the decrease in muscle strength. And so this is a huge issue. Of course, your swallowing, your paralysis, your loss of bowel and bladder control, all those things are kind of related to muscle weakness. So review slide number 4 really well. Let me click over here. One of the things that you definitely want to deal with multiple sclerosis would be what would be a priority nursing diagnosis for a person with multiple sclerosis. So that's one of the reasons that we had that learning activity, was for you to, first of all, determine what nursing diagnosis may be associated with a person with multiple sclerosis, but also what is a priority. Those are what your test questions are going to be out, not only for our unit exams, but for the NCLEX as well. They want you to know that you can prioritize different signs and symptoms and what interventions would you implement first. So keep that in mind when you're studying for a test. So we also talked about myasthenia gravis. And with myasthenia gravis, you're going to, again, have a major issue is going to be loss of muscle strength. And so this is going just about all the other signs and symptoms that are associated with myasthenia gravis is due to lack of strength or muscle weakness. And again, you'll want to look at your priority diagnosis for that. Let's see. About that. Never mind, mine. Give me a minute because I'm flicking through the slides instead of having the questions right there in front of me. So signs and symptoms of Parkinson's disease. Now, one thing when you think about Parkinson's, you think about slow, that the person has slow movements. They have partial or complete loss of muscle movement. They'll have tremors. They'll have a mask-like look on their face. They'll have difficulty chewing and swallowing, very similar to some of the disorders that we talked about earlier. But one thing that is classic and everyone associates with Parkinson's is Parkinson's gait, or the Parkinson's, what we call the shuffle. This is where a person is bent over slightly, so your center of gravity is going to be off. It's going to be wonky, and you don't have good balance anymore. Also, they don't have a normal stride from one step to the next. They have this shuffling, and they're trying to keep up with everybody, and so we have what they have, a propulsive gait. It's like they're trying to walk faster, but bless their little hearts, they're so unsteady that they are very unsteady themselves. So what is going to be an issue with that? A risk for falls. Yes, that's a nursing diagnosis that it's going to be huge safety considerations there for that. They will also have slurred speech, and they can be very emotional, labile. In other words, they can really get angry or confused or be very combative. They have it's starting to affect the brain quite a bit, and you'll have those types of issues come forward with being either depressed or having dementia. So that is slide number 21. You want to review. On Huntington's disease, we talked about the motor dysfunction and the cognitive dysfunction, but we also talked about how that is genetically passed down with a 50% chance of children getting the disease. And so we talked at length about, I didn't talk at length about it, Wendy talked at length about it, about genetic counseling, how important that is. So you may want to review that, and it's narrated, so it's not on a slide, but it's narrated in there somewhere. You may want to review your notes on that. And then let me hit down this brain. Just a minute. Okay, so we're talking about ALS now. This is on slide number 43 with the signs and symptoms of Lou Gehrig's disease. You'll notice here that this
You are currently the only person in this conference.
Did you hear that? It's my computer talking to me. But anyway, this is where, Ashley was here just monumentally for like 30 seconds. That's okay. It's okay, you leave. So when we're talking about Lou Gehrig's disease, or ALS, we want to compare it. It's very, very similar to some of the other neurodegenerative diseases that we have. But one thing that, for example, with multiple sclerosis, what is the difference between ALS and multiple sclerosis? Well, one thing that ALS includes that multiple sclerosis doesn't is complications with the respiratory systems. The muscles get so weak here that they cannot expand the chest. And so if the chest doesn't get expanded, the lungs don't get expanded. So just be aware of that. Let's see. With Guillain-Barré syndrome, you have a very interesting, this is really a very interesting disease in that it starts in the distal lower extremities. And so it starts in the toes, the person starts getting anesthesia, paresthesia there, and it starts to travel up the body. And so then the legs will start getting no innervation there, so they can't move their legs. And then it proceeds up the body. They'll lose a bowel and bladder control. They may get a paralytic ileus in the abdomen, and then it goes right up to the respiratory system. And the muscles, again, are so weak, they cannot expand. And so what happens there is that they have to be put on a ventilator. So again, this is very interesting in that if the person doesn't die, In the time period that the disease is active, then the disease process starts to kind of decline, and the people will get their function back in the reverse order that they got it. So very interesting. This on slide number 46. You'll want to review that. Okay, so that is all on the A&P lecture. Let me pull up really fast the last neuro disorders that we want to look at. And there's your wonderful objective 14 neurodegenerative disorders. Yeah, your favorite as well as mine. Okay, let me go back just a minute, see if I can find what I'm looking for. It's always nice when you can find what you are looking for. Okay, we are now on neurological disorders. So we are going to review that quickly. Let me get this in. Oh, I'm back. Of course, you probably saw me the whole time. I didn't see you. So let me pull this PowerPoint up. All right. Okay, so we're going to talk about stroke for just a minute. And you need to know what a stroke is. With your slides, it goes right immediately into a TIA. So what is a TIA? It's a transient ischemic attack. And it's where it's very, very small. It's very brief. It's like when you are in a dressing room in the mall and you come out and you don't know where you are and you don't know why you're there and you don't know who you're with and you're kind of lost for a short period of time. It's kind of very, very scary. And then all of a sudden it comes back to you. And so that usually lasts less than 1 or 2 minutes, or the slide says 10 minutes, but it's a very brief period of time. However, the frightening part about this is that if these episodes become more and more frequent, then you are likely just a foot away from having full-blown CVA or cerebral vascular event. So TIAs have to be paid attention to and dealt with so that you can reduce your risk of developing a CVA. So that was slide number 3. You also need to be on slide number 5 aware of the risk factors for men and women, but you also are aware that women have additional risks associated other than men. And that is on number 5. Number 6, you need to know the warning signs of stroke. Let's see, then you need to know the different types of stroke. Your ischemic stroke is always associated with a lack of oxygen. When we talk about ischemic, we're not talking about necrotic or dead tissue. We're talking about a lack of oxygen to the tissue, which causes inflammation. So ischemic stroke is usually it is definitely a result of an occluded cerebral artery, and that's because there is a thrombus up there where there's a blood clot that has blocked the flow of blood through the cerebral arteries, or it's an embolic stroke where there has been an embolus floating through the body. It could come clear down from the leg, but it goes up, it goes through the heart, and then eventually up to the brain. So it's hemorrhagic, and then there's a hemorrhagic stroke, and that's where there's bleeding in the brain that occurs in and around brain tissue, and it's usually a result of an aneurysm. Now, an aneurysm is where there has been severely profound hypertension, and it has weakened the walls of the usually very sturdy arteries. And so there becomes a little bulge, and that bulge becomes very thin, very much like a stretched out balloon. And so if the hypertension is not addressed and it's sustained and it's not dealt with or resolved, then that continued hypertension can cause that little area of the vessel to break, and the blood will seep out to the brain. And now that is called an aneurysm. Now, the thing about it is aneurysms can be big or they can be small. And so if you have a small one, blood will start to accumulate within the brain tissue, but it doesn't start to compress the tissue for a long time. When you have the aneurysm, you're going to have a very severe, horrible migraine headache that has nausea and vomiting. But if your aneurysm is very, very small, you'll still have that initial episode, but you can, up to a week later, up to 2 weeks later, enough blood can accumulate that it starts putting pressure on the other brain tissue and cause you to start having another episode of severe migraine and nausea and vomiting. So recognize that can happen. It doesn't have to happen. An aneurysm doesn't have to occur just because of severe hypertension. It can also occur because of congenital abnormalities or arterial venous malformation, which happens in embryo. Another factor that can cause profound hypertension is cocaine use. So there can be severe, when you talk cocaine, always think of severe vasoconstriction. Vasoconstriction plus high blood pressure, what does that equal? Yeah, another aneurysm. So just be aware that profound hypotension or hypertension can stop the blood flow to the brain tissue. What happens there is that the oncotic pressure at the capillary level does not allow for the free flow of fluids back and forth through the vessel wall or the one cell thick capillary wall into the brain tissue or anywhere else in the body. And this happens that that oncotic pressure that's wonky, either too high or too low, becomes either high or too low to force that fluid to go in and out of the capillary. And so what is happening is a tissue that capillary feeds is not getting perfused. So whenever you're talking about ischemia, you're talking about lack of perfusion. And inflammation. So when we talk about ischemia, we're talking about lack of perfusion. There you go. And that was on slide number 8. Okay, so let's keep moving. Okay, so when you're talking about emergency care for a stroke patient, the thing about the brain is that it's inside the body. Well, small thing, but we don't know where that problem is. We don't know if it's because of a blood clot. We don't know if it's because of an aneurysm. So the thing about it is that wherever that injury is occurring determines what kind of deficits the patient is going to have. So when a person comes in complaining of a severe headache, and they have nausea and vomiting, we definitely want to rule out stroke. But we have to assess their ABCs because this could be back towards the brainstem and affecting the control center, respiratory control center of the body. So we want to deal with that. Okay. Sometimes now, one thing on slide number 16 that it mentions is thrombolytic therapy. If it turns out that there is a clot, then we want to give TPA, which is a tissue plasminogen activator. And what is really interesting about this, it has to be started 4 to 5 hours after the event begins. So it's real important to determine really quickly if this is a clot or if this is a hemorrhagic stroke. Why is that important? Yeah, that was a poignant pause. The pause is there for you to think a little bit, because if you're putting in a TPA, which dissolves clots, it's basically affecting the blood type of thing. But if this is a hemorrhagic stroke, we don't want to give them blood thinners, more blood thinners. So again, we have to determine first what kind of stroke it is before we give the TPA. All right, let's move on. Okay, traumatic brain injuries, TBI. So we have open head injuries and we have closed head injuries. Open head injuries, obviously, going to be the same thing if you have an open compound fracture, which is going to be infection. Infection is going to be the major thing as well with the open head injury, and infection results in seizures. So if the person starts seizing, has had a head injury, it's an open head injury, and the person starts seizing, you can anticipate that the person may have infection already beginning. And that is on slide number 19. Types of brain injury are concussion. I want to stress with any kind of head injury, we want to decrease the metabolic demands of the brain. We want to decrease, for a metabolic demand, we're talking oxygen. So we want to decrease the brain's need for oxygen. So what we have to do here is decrease the stimulus so the brain doesn't have to deal with that. So we do look at, see slide number, I know it's in here because I remember it. Give me a minute. Oh, this is slide number 29. Go back and review this, because this is how you decrease stimulus to the brain. We do not want activity in the brain because that requires oxygen. And so we just need to decrease all the stimulus that we can. So look at the environment. We want low lighting, no visitors, no TV going, no lighting. Low lighting, just a very, very quiet environment. Positioning, we want a position sitting up in a semi-phalanx. Why is that? Because if we have the person laying flat, or if they have their head flexed, then what is happening? We're kinking the jugular vein, so to speak, which is going to occlude the drainage of blood from the brain, which will cause intracranial pressure. So we want to talk about that. We want to think about that. We want to avoid activities that increase intracranial pressure. And then again, we will administer stool softeners. Why? Because when you're trying to poop, you strain. Yeah, causes increased pressure. If you're throwing up, what happens? Increases pressure. If you're coughing or sneezing, what happens? Increased pressure. So we want to avoid all those things, because increased pressure is going to make the brain tissue ischemic. And if it's ischemic, there's going to be inflammation. If there's inflammation, there's going to be ICP. Intracranial pressure. That is slide number 29. There's nothing really on the test about brain herniation. Okay, let me keep looking. Oh, halo traction. One thing here that you really want to deal with is discharge teaching for the person going home on halo traction. Review, I have to tell you, I took questions directly from the student presentation on handouts. And if you look at the module, I'm sure you'll be so surprised, but there were probably 6, and then plus the pediatric student presentations on different aspects of care of the person that has a brain injury, or has had a stroke. If a person has difficulty swallowing, if a person has difficulty dressing, if a person has difficulty bathing, if a person has has the motor function to dress independently. What else did you people have? Rehabilitation, unilateral neglect. You want to go back and read all those presentations because why? Because the answers came directly from the presentation. Yeah, it did. Okay, let's see what else. Okay. All right, so you can have complications of spinal cord injury. So you need to look at slide number 36 about spinal cord shock and neurogenic shock and know the difference of that. You should, question number 37 should pretty much be a review from your fundamental days. One thing that is on the test is potential long-term complications with autonomic reflexia. And so you need to recognize what some of the signs and symptoms or stimulus, the signs and symptoms will be the stimulus to trigger the autonomic dysreflexia. So be aware of those and look at what the care is to immediate care is to elevate the head of the bed and remove the triggering stimuli. And that is in slide number 38. You'll have signs and symptoms of that and recognize that the person is going to have a very labile blood pressure, and so you need to be aware that this is a recipe for a stroke. So we need to recognize how dangerous autonomic dysreflexia is, and then look over here at the emergency interventions. Okay, people, I'm just talking to you. I think that's as good as it's going to get for you. If you do have any questions, just please give me a call. No, don't give me a call. Text me. It's better to text me because I don't always have my phone in the same room that I'm in and wouldn't hear the ring. And so I maybe a couple hours, but then, I see a text. So if you have any questions, let me know. Sorry that this was such a cluster. But I'm positive you all will do fabulous on Monday. All right, see ya. Just take at least 2 hours, this weekend to rest. All right, we'll talk to you later. Bye.